Okay, hello everyone, and welcome to the 42nd session of the online Optom learning series. Uh, Greetings, good morning, good afternoon from whichever part of the world you belong to. Without further ado, let me introduce to you our speaker for today. Today we have Dr. Arjun Gokani. He is an ophthalmologist who has trained in glaucoma at the Shankar Netralaya in Chennai, and he's been practicing as a glaucoma specialist in Mumbai since 2017. He is the head of glaucoma services at the KEM hospital and has performed over 500 glaucoma procedures and has a very keen interest in glaucoma valves and in terms of minimum invasive glaucoma surgery. And for today, he is going to talk to us about the role of anti-glaucoma medications and what medications to prescribe, how we are going to prescribe that, and some of the protocol, what he will brief us today about glaucoma medications. And I think you all have heard him as he mentioned that we as an optometrist being the first line of defense when it comes to patient care, it's very important for us to understand on what are the glaucoma drugs available and how are they going to be used. So thank you very much, Dr. Arjun, for giving us your time and taking up this session. And I think I'll just leave the screen to you now.
Thank you, Fakhruddin. I hope I can live up to that introduction. Thanks so much. So, just to start, I wanted to tell you that this topic is very important for you guys because you all are the first line of defense when it comes to glaucoma, and glaucoma being the second leading cause of blindness, especially in a country like India, which has a huge population. Every fourth or fifth patient or customer who walks into one of your shops, I'm sure many of you all are very successful spectacle shop owners and opticians, but every fourth or fifth person will be having some mild form of glaucoma. That's why I thought this is a very important topic and you all would learn a lot from it. So I'll be pressing upon the anti-glaucoma medications currently in use and some of the newer anti-glaucoma medications and how they behave in the eye vis-a-vis the side effects and the contraindications and things like that. Just a second. So I have no financial disclosures, though there will be some brand names mentioned during my presentation. Let's talk about the risk factors for glaucoma. So there are a number of risk factors: intraocular pressure, age, diabetes, central corneal thickness, myopia. However, the reason why I've highlighted intraocular pressure in this slide is it is the most important risk factor for glaucoma because it is the only one that we as medical practitioners and first line of defense like y'all, we can control this factor. The other factors like age, we cannot reverse someone's age, we cannot cure diabetes, we cannot change the central corneal thickness or the myopia of a patient, but intraocular pressure is in our hands, and it is the only factor that we can change and help prevent glaucoma or prevent the damage that glaucoma causes to the optic nerve. So we will be talking about how to manage intraocular pressure. So just before that, I wanted to explain how the RNFL, the retinal nerve fiber layer, and the optic disc gets damaged due to IOP. So the retinal nerve fiber layer is supplied by blood, which comes from the central retinal artery, which you can see over here in the diagram. And this blood is pushed to this retinal nerve fiber layer because of the ocular perfusion pressure, which is a factor of the blood pressure, basically. So when the ocular perfusion pressure is at a normal level, the blood is forced into the retinal nerve fiber layer and it nourishes that area. However, the intraocular pressure, on the other hand, is trying to prevent this ocular perfusion pressure from allowing blood to reach the RNFL. It is giving a counter pressure. But fortunately, in normal people, the ocular perfusion pressure is always higher than the IOP. So the ocular perfusion pressure always wins and the blood reaches the RNFL and nourishes the RNFL. However, in glaucoma, when the IOP reaches above a certain normal amount and it goes above the ocular perfusion pressure, it prevents blood from reaching the RNFL, and therefore the RNFL is not being nourished by blood, and slowly the RNFL starts dying off. And that's what we see as RNFL defects in OCTs, and we see optic nerve atrophy in advanced glaucoma because these RNFLs are slowly dying out. And because they die out, we get visual field defects in glaucoma. So this is just a principle of how IOP plays a role in causing optic nerve changes and hence visual field defects. So just a brief on how the IOP is maintained in the eye. So the aqueous which forms the eye, so the eye is like a balloon filled with water. So the aqueous is the water inside the eye, and it is formed in the ciliary body, which is labeled as A over here. After being formed, it moves to the anterior chamber through the pupil, and it is drained out through the trabecular meshwork and Schlem's canal labeled as B, and the uveoscleral pathway, which is labeled as C. So now, as and when aqueous is formed, the balloon keeps filling up, means the eyeball keeps filling up. And as and when the aqueous gets drained out, the balloon keeps shrinking. So basically, it's a very microscopic shift, which doesn't affect the vision, but it affects the pressure. So if we overfill a balloon, the pressure inside that balloon will be very high. And when we deflate the balloon, the pressure in that balloon will be very low. The IOP and the aqueous play a similar effect on the eyeball. This next diagram explains at which level of IOP change do the different drops act. So as you can see in the top right over here, beta receptors, carbonic anhydrase inhibitors, alpha receptor agonists, all these things I'll be explaining further in detail later on in the talk. But these three categories, they prevent the aqueous humor production, and hence they reduce the IOP, because the less aqueous humor that's produced, the less the pressure inside the eyeball will be. And on the other hand, trabecular outflow and uveal outflow will cause IOP to drop, because aqueous is now moved out of the eyeball, and prostaglandins act on the uveal outflow in terms of they increase the uveal outflow. Hence, the IOP will come down due to prostaglandins. Now let us start talking about the individual drug categories. So we start with prostaglandin analogues. As I mentioned, it increases the uveal outflow. So how does it do that? It causes gaps in the ciliary muscles to increase in size. So when these gaps increase, the resistance to outflow of the aqueous has reduced, and therefore there is a smooth outflow of aqueous from the eyeball, causing the pressure to drop. The drop is given once daily at night. The effectivity of the drop is that it reduces the IOP by 25 to 35%. The IOP comes down after 6 hours of application. This is an important point, because we cannot use this drop in emergency cases, because it takes around 6 hours for this drop to come into effect. So if you have someone in your clinic or in your shop coming in and their pressures are very high and you want to bring it down immediately, these drops cannot be used, because it takes 6 hours for the drop to come into effect. The washout period. Washout period is a concept I'd like to explain towards the end of this talk. It's a very important concept, but for now, just remember that the washout period for this category of drops is around 4 to 5 weeks. The common drugs, you all will all probably know these: latanoprost, bimatoprost, travoprost. The image over here are some of the more popular brands that are available. You all are all familiar with these brands, Zaletan and Lumigan. Now, the side effects of these drops. So all glaucoma medications come with their own set of side effects, and the patients are usually not free of any of them. So to explain to you, I put these images on the side. The side effects of prostaglandin analogues mainly is conjunctival congestion, periocular pigmentation, as you can see over here, eyelash elongation, as you can see in the first image. There is a very elongated eyelash in this gentleman. It also causes uveitis and cystoid macular edema. Therefore, the contraindications for this drop are people who have who have just undergone eye surgery like a cataract or a retinal detachment surgery, because they are more predisposed to getting uveitis and CME. Pregnant women are contraindicated, because this drop causes contraction of the uterus. So it is not given in people who are in their third trimester of pregnancy. And people who have allergies to this drop are contraindications for this drop. The next category is beta blockers. So beta blockers also acts on aqueous humor production in the sense that it reduces the aqueous humor production, because these act on the beta adrenergic receptors in the ciliary body, which help in promoting aqueous humor production. Therefore, when they are blocked, the aqueous humor is not produced. This is given twice a day, morning and night. It also causes a 20 to 25% IOP reduction. This one, the IOP comes down in 2 hours. So this can be used as one of the cocktail of medications used in acute cases. The washout period again is 4 weeks. The common names timolol, bitaxolol, very commonly used these days. The side effects of these drops are redness, itching or dry eye sensation, blepharoconjunctivitis, watering of the eyes, and superficial punctate keratitis. Basically, every side effect that you can attribute to toxicity towards the corneal cells and the conjunctival cells or the tear film can be attributed to this category of drops, because timolol and bitaxolol and other beta blockers are all very toxic to corneal cells and conjunctival cells, and they also deform the tear film. Therefore, the patients will not have a smooth tear film to lubricate their eyes. The contraindications in this category are bronchial asthma and chronic heart failure. So bronchial asthma is something that I learned the hard way. So my grandfather used to use this drop, and this is when I was in school, so I didn't know better that time, but he basically was an asthmatic, and he also had glaucoma. So, and you know how when glaucoma patients put drops, not just one drop falls in, but 3-4 drops fall in. And one day he started having severe wheezing after putting drops, and he told me that he had put 3-4 drops in his eyes. And that's when we took him to the eye doctor, and the eye doctor told us that asthmatics usually get affected by beta blockers because the bronchioles in our chest are also contain beta receptors, which when they get blocked, the bronchioles constrict and they exacerbate asthma. In chronic heart failure patients, the heart rate is reduced, so we do not give beta blockers to such patients. The third category is the alpha-2 agonists. So the mechanism of action is same as beta blockers, except that it acts on the ciliary body vessels in vasoconstricting them, and hence these ciliary bodies don't create as much aqueous as they were when the vessels were dilated. The dosage is also 2 times a day, morning and night. It also causes Iop reduction by 20 to 25%. Action starts in 2 hours. The washout period of this category is 2 weeks. The drug's name is brimonidine, apraclonidine, again very commonly used drops. The side effects of this drop is contact dermatitis. As you can see in this image over here, when the drops overflow over the eye and onto the cheek, it is known to cause contact dermatitis in a few patients. Hyperemia is very common. Patients will come to you with red congested eyes. Drowsiness is another effect of this drop because it causes some amount of CNS depression, and anterior uveitis can be exacerbated by this drop. The contraindication for this drop is children and pregnant women because, as I mentioned, it causes a CNS depression. Therefore, children and pregnant women, the fetus in the pregnant woman is more susceptible to having CNS depression, and they can go into an unconscious state. So it should be completely avoided in children and in pregnant women. The fourth category is a carbonic anhydrase inhibitor. It inhibits production of aqueous by inhibiting the production of HCO3 and H+ ions, which are necessary for aqueous production. This drop can be used 3 times a day. Its effectivity is less than the other categories. It only causes a 15 to 20% reduction in IOP. The effect starts within 2 hours of application. The washout period is also 1 week, and dorzolamide, brinzolamide are some of the categories in this, some of the drugs in this category. The side effects are superficial punctate keratitis, headaches, contact dermatitis, as you can see in this image over here, and allergic reactions. So as this is a sulfa drug, anyone who has a sulfa drug allergy is susceptible to getting an allergic reaction, and there should be contraindications for patients with sulfa drug allergies. The newer category of drug, which is the ROCK inhibitors, this is it's the latest, most popular drug right now in the market because it's new. So this drug acts on increasing the outflow of aqueous from the trabecular meshwork. It basically remodels the spaces between the trabecular meshwork cells, allowing more aqueous to flow out of the eye. Its dosage is 2 times a day. So ripasudil, which is the molecule which is available in India right now under the brand name Ripatech, is one of the drugs in this category. The side effects are very few. Conjunctival congestion, conjunctival hemorrhage, and blepharitis are what has been documented as of now. There are no contraindications as of yet, but again, it's a fairly new drug, so it should always be used with precaution. Now the fixed drug combination. So as you can see in the image over here, you all must be very familiar with these drops. A lot of patients are using these drops these days, and they're very easily available, especially in India. The advantage of fixed drug combination. So what are fixed drug combinations? They're basically two glaucoma medications in one vial, in a perfect combination, in a perfect formulation. In one vial, they put two glaucoma medication. The advantage of this is that the patients are more compliant to using two drops in one vial as opposed to two separate vials for two separate drugs. So the compliance is improved when we use these FDCs. The second one is, as we are putting only one drop as opposed to two, less preservatives are going into the eye. Therefore, it is less toxic to the eye. And the third one is, because the patient has to buy only one drop as opposed to two, there's a cost benefit attached to it. Now, some of the systemic medications that we use in glaucoma, but these are usually used only in acute cases when a patient has a acute incidence of IOP spike, or before an operation when we need to quickly bring the pressure down, then we use systemic medications because they cannot be used for a long term. So the oral medication is Diamox, which is also, the chemical name is acetazolamide. It reduces the aqueous production in the same way that carbonic anhydrase inhibitors reduce it, by reducing the H plus and the HCO3 minus ions, which are necessary for aqueous production. This reduces the IOP by a staggering 40 to 60%. So there is a tremendous drop in IOP, and the effect starts after 1 hour, which is sooner than most of the drops, and it maintains the low IOP for 6 hours. Therefore, we give one tablet 3 times a day to such patients. The uses, as I mentioned, is in acute angle closure glaucoma. Suppose we need to bring the pressure quickly down before we do the laser PI, or we take the patient up for a trabeculectomy. We'll give the patient a dose of Diamox for a short term. Then pre-op IOP reduction, if we're going in for a corneal transplant, or if we're doing a trabeculectomy where the pressure is high before the surgery, we bring it down with Diamox. And if there's a post-op IOP spike due to some retained viscoelastic in the eye, or due to some inflammation, if we just need to bring the IOP down for a week or so, then we'll give a week of Diamox tablets. The side effects of this tablet are, because it's a systemic drug, there are a lot of systemic side effects. The main ones are tingling sensation. Patients will always complain of tingling sensation, change in the taste in their mouth, things like that. But the most scariest one is the electrolyte imbalance, and especially in patients with kidney failure, the electrolyte imbalance is magnified. Therefore, we do not give this drug in patients with kidney failure. The second category of systemic anti-glaucoma medications are the osmotic agents. So how do these osmotic agents work? These osmotic agents are consumed, or they are given through IV, and they go and make the blood very thick. They increase the osmotic value of the blood. Therefore, this thick blood then goes and pulls out the fluid from the eye and causes vitreous shrinkage. Once the fluid from the eye is pulled out, the IOP itself falls down dramatically. So this is also used in cases where we need to reduce the pressure very rapidly, and in acute cases like angle closure, lens-induced glaucoma, in pre-op before glaucoma surgery or corneal transplants. The problem with these medications is that because there is a fluid overload in the blood, it causes problems in patients who have kidney and heart problems. And it also causes electrolyte imbalances, and it should not be given in patients with head trauma, because it causes an increase in the intracranial tension in patients who have head trauma. Therefore, it should be avoided in anyone who has a kidney, heart, or a head problem. The oral medication in this category is oral glycerol. It acts within 30 minutes and it lasts for 4 hours. The dosage is 30 ml of 50% solution 3 times a day in orange juice. So why is it given in orange juice? Because alone, if you ask the patient to have it, the patient will not like the taste, because it's extremely sweet and it is extremely concentrated. Therefore, we are supposed to dilute it in orange juice or lemon juice, and we give it 3 times in a day. And the IV formulation of this category is mannitol, which acts within 15 minutes and it is used up to 6 hours. So the dosage for this is around 250 ml in an average weighted patient of 25% IV mannitol. So the mannitol available in the market these days is 25%. So around 250 ml given slowly over a span of 10 minutes is ideal to bring down the pressure. So you might want to know which medicines to use first and which ones to use second, and which medicines to start with. Since I've mentioned at least 5 or 6 categories, let me start with what I usually practice and what is usually practiced throughout the world. So we start off with one medicine, and usually the first line of medicines for me and most other practitioners is prostaglandin analogues, because the patient has to put it once at night. They don't forget. The compliance is very good. The side effect profile of prostaglandins is also on the milder side. It doesn't cause as much ocular surface problems as the other drugs do cause. The only problem with prostaglandins is it's fairly expensive. So poor patients I usually do not prescribe this drug. Uveitic patients, because prostaglandins promote uveitis, I do not give this drug to people with uveitic glaucoma or post-operative patients after a cataract or a corneal transplant surgery or a retinal detachment surgery. So in those cases, I'll give a beta blocker. But the beta blocker also, we must remember that in patients with bronchial asthma and reduced heart function, we cannot give a beta blocker. But usually one of these 2 drops is more than sufficient to bring down the IOP. If the IOP doesn't come down with 1 drop, I usually move on to a second line of management, where I'll use either an alpha-2 agonist or a carbonic anhydrase inhibitor. Again, the contraindications should be obvious to me, and I cannot give it to people who are contraindicated. In acute cases, as I mentioned, when patients come with the acute angle closure glaucoma or a lens-induced glaucoma, where the pressure is still below 40, but I need to bring the pressure down rapidly, I'll give Diamox. But if the pressure is above 40, then I'll usually start on an osmotic agent, either glycerol or mannitol. Mannitol usually is a little difficult to give because you have to admit the patient and keep him in your facility. So if you don't have too much space in your particular facility, you can always give glycerol. So I've created a sort of algorithm of my medical management of glaucoma. So as I mentioned, I usually start with a first line drug, and then I ask myself, did the IOP drop? I'll wait for 3 to 4 days. After that, I'll check the pressure again, and I'll ask myself, did the IOP drop? If the answer to that is no, then I'll use another first line drug, and again I will ask myself this question, did the IOP drop? If the answer is yes, my second question is the IOP normal? If the answer to that is no, then I will add a second line or a first line drug, and again I will ask myself the same question, whether is the IOP normal? If the IOP now is normal, if the answer to that is yes, then I will continue using this medication. Whatever has kept the pressure to its normal value, I'll continue using those drops. However, if again we get a no, then again we add another glaucoma medication, and we keep doing that till we've added at least 3 or 4 categories of drugs. However, after 3 or 4 categories of drugs, if the IOP is still not in the normal range, then we have to counsel the patient for either a laser procedure or a surgical procedure. It could be trabeculectomy or it could be minimally invasive glaucoma surgery, depending on the severity of the glaucoma and the amount of damage. Now, what causes the side effects of glaucoma medication? So there are 4 points that cause the side effects. One is the innate toxicity of the drug molecule itself. For example, timolol, brimonidine, etc. are innately toxic to the ocular surface. They cause damage to the corneal cells and the conjunctival cells, and they also cause tear film instability. Therefore, these patients will have more ocular surface complaints like SPKs, watering, redness, irritation, things like burning sensation, things like that. Second point is the pH of the drops. So a lot of these drops, the manufacturers will add an acid buffer to these drops to increase the shelf life. This brings the pH of the drops to around 5 to 6, which is an acidic pH as compared to the ocular surface and the eye pH. So these drops, when used on the eyes, they have a slightly acidic effect on the eyes, and they cause side effects due to this low pH value. The third point is, because glaucoma patients have to be treated lifelong, the drops are used for a number of years. So the toxicity of the drops keeps building up inside the eye because of this long-term usage of the drops. And the fourth and one of the most important reasons why side effects occur due to glaucoma medications is the preservatives used in the drops, particularly the BAK, which is benzalkonium chloride, which is used in a number of glaucoma medications, at least available in India. And this particular preservative, it causes a detergent effect on the tear film. It disrupts the lipid film, and therefore it decreases the stability of the tears of the eyes, and patients will complain of ocular surface complaints. It also has a negative effect on the conjunctival cells and the corneal limbal cells. Therefore, it causes a number of surface problems. Now, how to reduce the side effects of the drugs? So as you can see in this image over here, there are these single-use 0.5 ml vials that are available, in which glaucoma medications are manufactured. Unfortunately, they are not available in India as of yet, but they are available in the Western countries and in some of the Asian countries also. They're called UNIMs. These are completely preservative-free because they're a single-time use and throw vials. Once you open them, you have to use them and throw them off. So there's no question of preservatives in this. The second and the third point, which is BAK free drops and low toxicity preservative drops, these are available in India. As you can see, Alphagan Z in the image over here, this is a drop that contains a preservative which is Soft Zia. The name of the preservative is Soft Zia, and it is much less, it is less toxic than BAK. And Glaucoma PF, which is also BAK free, contains a preservative called Purite. So this Purite and Soft Zia are much less toxic than the BAK, which is there normally in glaucoma medications. And the fourth point is in cases where the patient is intolerant towards the side effects of the drops, and no matter how much we change the drops to preservative free or low toxicity preservatives, if the patient is complaining of side effects, we have to counsel this patient for a laser option like a selective trabeculoplasty, which is very non-invasive and effective in bringing the IOP down in around 70 to 80% of the people. And or we can also counsel them towards a minimally invasive glaucoma surgery or a trabeculectomy or a valve, depending on the severity and the lifespan of the patient. So my take home points is, always remember that drops have a washout period. So in the beginning, I said that I'll explain what washout periods is. So basically the concept of washout period is that when we apply anti-glaucoma medications in the eye, these glaucoma medications, they get attracted to the proteins inside the eye, like the iris protein or the corneal protein or the lens protein, and they get attached to these proteins. And as and when we keep adding more and more drops over the months or years, these proteins will get concentrated with this drug. Now, suppose we have a patient who has been on anti-glaucoma medications for 5 years and has been completely, the pressures have been normal and there's no progression. And we want to stop the drops now. So we stop the drops. When do we check the pressure again to see whether the patient is able to maintain a normal pressure in spite of stopping the drops? So we have to wait for a washout period. So this washout period is basically the amount of time it takes for these proteins to get rid of the drugs that have been applied to them for so many years. So in most of the drops, the washout period is 4 weeks. Except for two categories. In alpha-2 agonists, it takes 2 weeks for the washout period to occur, and in carbonic anhydrase inhibitors, it takes 1 week. So this is it's a little difficult to remember all this, but all you have to remember is that all drugs 4 weeks, alpha-2 agonist 2 weeks, and carbonic anhydrase 1 week. So we have to call these patients back after the washout period is over to check the pressure, to see whether the pressure is actually normal or whether the pressure was normal because the proteins inside the eye were still releasing the drug. So we call them after the washout period. The second point I'd like you to remember is you have to counsel the patient about the side effects. When a glaucoma patient comes to you for the first time, he has to be made to understand that these drops will be used probably for the rest of his life, and they come with their own set of side effects. So we have to lay down the entire it's like a menu of treatment in front of them, and we have to ask them what they will prefer as per their quality of life expectancy. So medications is one, lasers is another form of treatment that we can explain to them. Surgical options we can now explain, because nowadays we have surgical options which are so minimally invasive and have such less complications that they work better than medications because the effect of these surgeries lasts for 5 to 10 years. So the patient can live a normal life without using any drops for the next 5 to 10 years. So it's very important to explain the side effects and the long-term usage of the drops to them. If the patient shows any intolerance towards drops, we must tell them about the alternative therapies like laser and MIGS. And fourthly, it's very important to take a very good drug allergy history of these patients because there are a lot of allergy. These drugs are very allergenic. So it is important because, and especially carbonic anhydrase inhibitors, because patients with sulfur drug allergies will not be tolerant towards these drops. So it's important to know if the patient is allergic to any drops or not. That's it. So finally, I'd like to quote a dialogue from one of the masterpieces of Hollywood. So in Shawshank Redemption, the character says, "Geology is the study of pressure and time." I'll say glaucoma is the study of pressure and time, and that's all it really takes, pressure and time. So basically, if you don't want your optic disc to look like the tunnel created by the character in the movie, then we have to keep the pressure down to a normal for a long period of time. That's all I'd like to say. Thank you.
Thank you, Dr. Arjun. I think that was a very comprehensive presentation, and I think everybody here would have definitely got a recap of what we have already probably learned, and especially knowing some new glaucoma medications, what you have just discussed with us. So thank you so much. There's one question here. I'll just read that out for you.
Sure.
Considering the practice of India, optometrists are not allowed to practice either drugs or any surgical procedures. So only if ophthalmologists have to practice for anti-glaucoma, then why not trabeculotomy is the first line of treatment, as it avoids all side effects that comes with the drug. So I think he wants to know why trabeculectomy is not the first choice and why drugs are probably.
So there are 2 points for this. One is trabeculectomy also comes with its own set of side effects. It has its own complications and it is fairly invasive. So usually for young people who are phakic, who haven't had a cataract surgery yet, trabeculectomy might not be the best way to go because it can cause not only fluctuations in your IOP, but it can cause a cataract to form early. Obviously, if the patient really needs a trabeculectomy, there is no other choice, but we have to go for a trabeculectomy. Second point is, a lot of the patients who come in India are not very affording. So they do not want to go in for a surgery immediately because it's a one-time expensive affair, as opposed to drops, which are, a monthly expense for them. So expense is another issue for opting for a medical form of treatment. However, instead if we go in for a minimally invasive glaucoma surgery, which could be fairly cheaper also and less invasive, then maybe that's the new way to go. Except for these surgeries are fairly new, so we need to counsel the patients and the optometrists and everyone about how these surgeries work, etc. But yes, that's a good question, because trabeculectomy might not be my first option, but I'll definitely go in for a minimally invasive glaucoma surgery if I get a patient who's willing for it.
Okay. And the other question is, this is not towards the drugs per se, it's towards the glaucoma perspective, but I'll just ask you, since being the specialist, what do you think would be the reasons on the changes of IOP throughout the time of the day? If you want to summarize into 2 sentences.
So this has a lot to do with so basically there's a diurnal variation in the IOP. This has a lot to do with the mechanics of the aqueous production. At certain times of the day, the aqueous production is more than the other. It also has something to do with it's in relation with the blood pressure of the patient also. It has something to do with the episcleral venous pressure. So all these factors keep fluctuating throughout the day. It's like your pulse rate also keeps fluctuating throughout the day. At night it's lower, in the day it's more. So these things all are intertwined. So IOP is also intertwined into that whole mechanics, and therefore you have these fluctuations in the day. But it is important to see by how much the fluctuation is. So if the fluctuation is under 8 millimeters of IOP, then the patient is normal. But if the range of fluctuation is a lot, if it's above 8 millimeters, then we need to evaluate these patients for glaucoma, because they are at a risk of getting glaucoma.
Yeah. So there's one more question. I think I would like to a bit rephrase, because the attendee is asking, Indian optometrists are not allowed to prescribe anti-glaucoma medication. I would say not only Indian optometrists, but most part of the world globally, optometrists are not allowed to prescribe glaucoma medication, and unless you have done a special course or you are having therapeutic rights by doing a special
Right.
course for that.
So till then, I think it's always better to have a knowledge of what drops can be used and what are the side effects and what are the different effects these drops have on the eyes. In spite of being able to prescribe them or not, you should have that knowledge with you, because it's always easy to explain to patients who come to you, or clients or customers who come to you, why they're seeing or feeling something in their eyes due to the glaucoma medication.
Yeah, and it all boils down to your first point when we started the session. You said optometrists being the first line of defense. We would be having that time when we are doing history taking, and you emphasized on sulfur drugs, or allergic to sulfur drugs. We must be able to know while we are doing the history taking. So
another important point is you all should also know when to send the patient to an ophthalmologist and when you don't need to. That's another very important thing.
That was my second point, that we can together co-manage the condition, because optometrists can do the tests such as IOP measurements, the OCT, and the ophthalmologist can look at it and then decide on what medications to be prescribed. So it's like a co-management thing, right?
Yes.
Let's take what's the science behind normal tension glaucoma? This is again on glaucoma again.
So as I mentioned in one of my slides, where I had drawn the diagram of the eyeball with the IOP on one side and the ocular perfusion pressure on the other side. Sometimes the patients will have a normal pressure, however they'll still have glaucoma because their ocular perfusion pressure is too low. So that is another way of tipping the scale towards glaucoma. If the ocular perfusion pressure is normal and the IOP is high, then also you can have glaucoma. If the ocular perfusion pressure is low and the IOP is normal, then also you can have glaucoma. So in normal tension glaucoma, what happens is the ocular perfusion pressure is too low to overcome even the normal IOP. So the RNFL and the optic nerve are not getting enough blood and not getting enough nourishment because of that, and they get damaged eventually.
And what's your take on the glaucoma medication usage along with steroids?
So steroids obviously causes glaucoma. It's one of the reasons why IOP builds up. The only time I've used steroids in a glaucoma patient is when they had severe allergies, and I used a very mild form of steroids, and it was used for literally 1 week, and then I stopped it immediately. But otherwise, I do not advise anyone to use steroids. And now with the newer anti-allergic drugs like bepotastine or NSAIDs, like even Nevernac is very effective. You don't need to use steroids anymore, at least to manage allergies due to these glaucoma medications. The only time I'll use steroids in association with glaucoma is in uveitic glaucoma. There you have to use steroids. If you don't take care of the uveitis, then the glaucoma will persist no matter how many medications you use.
Yeah. And I'm just taking the ones mostly on the medical aspect and the the drops and medication aspect. One question is about congenital glaucoma, where mostly surgically treatment is being advised. Surgical treatment is advised. So what's your take on that? For congenital glaucoma, do you prefer to do surgical treatment, or you would still start with drops or something like that?
See, the thing about congenital glaucoma is that when the kids are very small, you need a short management technique for these kids, because you cannot keep putting them under anesthesia to check the IOP and check the corneal diameter and the optic disc and everything. Because when they're awake, you cannot check all these things. You have to put them through anesthesia. So yes, I usually, if I see that the patient has clear-cut glaucoma where the horizontal corneal diameters are more than 12 millimeters. 11 is the cutoff, but I'll give 1 millimeter leeway. And if I see half striae, or if I see that the sclera is becoming bluish, then I'll definitely go in for a surgical option. And my surgical option is usually an external trabeculotomy.
Okay.
Yeah.
And I think we'll take one or two last questions, which
Sure.
are more, yeah, this one, except referring the patients, I mean, an optometrist's role is to refer the patients for further glaucoma management. So as an ophthalmologist here, what do you think as an optometrist we can help you? I mean, this is just a summing up of what we have already talked.
So I don't know if you all have these machines commonly. Do you all keep A scans and pachymetries and OCT and visual field analyzers commonly with you all?
Normally, if there is a primary eye care practice, most of the people would have those instruments. Probably not A scan, but an OCT, fundus imaging, Goldman applanation tonometry with the slit lamp on.
Okay.
So all these three things are definitely there.
So basically, I would say that to do a full investigation and evaluation of the patient in terms of their pachymetry, do a OCT RNFL, and if you have a more advanced OCT, then you can do a GCC also, which takes care of the RNF, the ganglion cell layer in the macular region. Doing a visual field if you have the availability, and checking the pressure and the angles and everything, and summarizing everything in a nice report and sending the patient will be extremely helpful.
Yeah.
You know, many times if I get such a report from an optometrist also, and especially if the patient lives far away, I'll see the patient once and then I'll ask the patient to just follow up with the optometrist, and I'll liaison with the optometrist regarding whether there is any progression or not. If there is, then I'll call the patient back. This is usually for patients living in small towns and who have come all the way from villages and things like that.
Yeah. So again, co-management.
Exactly.
Yes. And for how long do you think we can give a Dimox tablet and safely? I mean, how long we can give a Dimox tablet safely?
So
is there any particular dosage?
I have seen patients who've been on Dimox for even 6 months, but I do not advocate that, because in the long run it causes a lot of irritation and discomfort to the patient. It causes a lot of gastric problems, and patients may be able to tolerate it, but we do not know what the long-term effects on the kidney are. So I prefer not to use it for a very long term, and there's no reason why we should use it for a long term also. If the patient's IOP is not coming down with any other method other than Dimox, I just post the patient for a surgery.
Yeah. And is there a role of insulin in glaucoma management?
Insulin, I've never heard of that. No.
Yeah.
There's no role of insulin.
There's no role of insulin. Yeah. So yeah, I think somebody is asking your slides, but I think the session is recorded. You can definitely go back to our YouTube channel, and you can listen to him over and over again to get your doubts clear and understand it more deeply. So that would be one of the things. Yeah, I think we have taken most of the questions, which were mostly related to the medical aspect of it in prescribing drugs. Somebody also mentioned that optometrists in the USA and Canada are allowed to manage glaucoma through medications, except the procedures. So yeah, that's one thing which people would definitely like to know. And again, I believe that those optometrists in the US and Canada have some rights, or the law allows them to do that only after taking a special course, or having that therapeutic degree on that end. So it's complicated. So I think thank you very much. We would like to thank you for taking up this time and helping us to understand the management of glaucoma in terms of prescribing medications very, very thoroughly. Thank you, Dr. Arjun.
Thanks, thank you for the opportunity.
Yeah, most welcome. So we are sharing the feedback form cum certificate request link onto the chat box. And I would request everyone to fill that correctly, because we have found that some names were not that written correct. So just want to ensure that you get your names and the details correct. That will help us to prepare your e-certificates and send out to you. We do have sessions next week. Next week and is the contact lens week. So we have two sessions, one on orthokeratology and one on toric contact lenses. So please stay tuned. You will be receiving the meeting links and the speaker information in due course. Until then, stay home, stay safe, and see you all again next week. Bye-bye. Take care.
Bye. See you. Thank you.
Thanks.